Yes, it's slowing down. I think we're about ready to start. We have 57 people here ready to go.
Great. Okay, so my name is Cynthia Fisher. I'm the president of the Lucia Flagler chapter of the ACLU of Florida. This is the ACLU of Florida chapter's Racial Justice Speaker Series. I am so excited that we are here in October. We launched this in February. And we've been meeting monthly ever since, and it's been a huge success. And thank you to all of you for being here. I've already gone through the protocols. So at the end, so as the presentation goes on, you can go ahead and put your questions in the chat, and then there will be a designated Q&A time at the end. Our next speaker, so you can mark your calendars, will be November 9th. It is still the second Tuesday of the month. It's just that November starts really early. So on a Tuesday, so November 9th, and it will be Dr. Leroy Long III speaking about educational equity and racial justice in STEM. So that should be fascinating. There was just a reference to that, a real life reference to that on a show I was watching on Netflix this week. And I thought, okay, well, there you go. It's an engineer, and she said, this is a real problem. But anyway, mark your calendars for that. And now I'm going to get to the matter at hand and introduce Dr. Brawley. And I hope that all of you who were here before with the mishap have returned, and that we have new people as well. And he is so gracious to share his time with us. So Dr. Otis Brawley is an American physician and the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University, where he leads a broad interdisciplinary research effort of cancer health disparities at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins Kimmel Cancer Center, working to close racial, economic, and social disparities in the prevention, detection, and treatment of cancer in the United States and worldwide. As the Kimmel Cancer Center's Associate Director for Community Outreach and Engagement, he also directs community outreach programs for underserved populations throughout Maryland. He is the co-author of How We Do Harm, A Doctor Breaks Ranks About Being Sick in America, published in 2012, which exposes the underbelly of healthcare today, the overtreatment of the rich, the undertreatment of the poor, the financial conflicts of interest that determine the care that physicians provide, insurance companies that don't demand the best or even the least expensive care, and pharmaceutical companies concerned with selling drugs, regardless of whether they improve health or do harm. So I am super excited to have him here, and he's so gracious, as though we're doing him a favor, letting him be here and nothing. So so gracious all the time. And I am thrilled beyond belief to have you here and so appreciative of your time. So I'm going to stop talking. So we'll give you the maximum time for everyone to hear you.
Well, thank you, Cynthia. It's really wonderful to be here. I truly, truly appreciate the invitation. I also apologize for the confusion last July, I think it was. I'm sharing my screen here, and I'm going to blow this up and flip this over, swap. Yes, so now I think you can see the slides. I am a medical oncologist and epidemiologist. I'm a professor at Johns Hopkins University. I study a great deal having to do with health disparities. I was very fortunate that I worked for David Satcher when he was Surgeon General, and he really started the academic field of health disparities. I do some consulting for a number of companies and serve on a couple of boards. I thought you should know about that. And I did publish a book about 12 years ago. Some of what I'm going to talk about is in the book. Much of the information I'm going to talk about is much newer than the book. In December of 1971, Richard Nixon signed the National Cancer Act and really put cancer research on steroids in many respects, if you'll let me use that analogy. And one of the things that he did was created a surveillance program that has allowed us to look at cancer in the population and look at what's going on that's good, what's going on that's bad, and so forth. Over the next 35 minutes or so, I'm going to discuss healthcare costs, talk a lot about disparities and even magnitude. First, let's talk a little about the economics of healthcare, the cost of healthcare. In the United States, in 2019, the last year, which I will call normal times, we spent $3.8 trillion on healthcare. That's 17.7 cents out of every dollar. Last year, it was far more than that because of COVID. But 17.7 cents out of every dollar spent on healthcare. Of every dollar spent, 17.7 cents was spent on healthcare. That's $21.43 trillion spent on everything in the United States in 2019. To give you an idea of a trillion, a million seconds ago was Monday of last week. A billion seconds ago was about the time that George H.W. Bush, the elder Bush, was inaugurated as president. And a trillion seconds ago was 32,000 years ago. A trillion seconds ago was 24,000 years before the first recorded civilized man. We've only known that we've been on the planet for 12,000 years. 17 cents out of every dollar, if you look at other countries that we like to compare ourselves to, the number 2 country is Switzerland at 11.7% of its GDP. And you can see a number of countries that we typically compare ourselves to. One of the things I want to point out is they have disparities, but the disparities in their country are not nearly as broad as they are in the United States. We really don't get what we pay for, in that we have some of the worst disparities in the world among civilized, or I should say among Western countries. And we have these other countries frequently have better outcomes than we do in the United States. So we really don't get what we pay for. Another way of looking at various countries is looking at the GDP per person, how much money is brought into the country or how much money is spent in the country per person. This is Singapore, $120,000 per person, but their healthcare costs a little over $5,000. Here's the United States. We have a very high per person cost of healthcare and are about $60,000 spent for every man, woman, and child in the United States. Our costs have been growing over time compared to other countries in Western Europe and developed countries. On a per person basis, you could get it from the last chart, about $11,000 per man, woman, and child spent on healthcare in the United States in 2019. By that metric, Switzerland is number 2 and Germany is number 3. This is the average among Western European countries. We spend a lot of money on healthcare. Now, the American healthcare system, there's too much emphasis on treatment and not enough emphasis on risk reduction or prevention. Even in the way we train our doctors versus in Europe, our doctors are trained to make the diagnosis and treat, whereas in Europe, the doctors are trained to figure out how to reduce risk. Sometimes they end up being the exact same thing, but the justification in Europe is more on risk reduction. The justification in the US is on treat. Now we can talk about hypertension in the question and answer period if we want. Now, it's estimated that about 30 to 40% of American medical costs are either waste or fraud. That's according to Don Berwick, who ran CMS during part of the Obama administration. And really, my talk is going to be a huge plea for the use of rational medicine, to get away from threats of rationing medicine. We already, by the way, ration medicine. That's what this disparities talk is going to be about, and start rationally using medicine. You see, some Americans consume too much medicine and they're harmed because of that. Some consume too little and they are harmed because of that. And we can decrease the waste and improve overall outcomes if we just started being scientific. Again, rational use of medicine, not the rationing of medicine, or irrational practice of medicine, which is really what's going on. Indeed, I think, how can we provide adequate high quality care to include preventive services to populations that often don't receive that is the most important question that we can ask in medicine, and maybe one of the most important political questions as well, because unnecessary care is going on right now, and it's consuming precious resources. It's interfering with our ability to provide necessary care, and it's the cause of a lot of disparities. Now, I'm a cancer doc and a cancer epidemiologist. I have to show you these graphs. Let's look at 1900. For every 100,000 Americans, 64 died of cancer. And it rose throughout the 20th century, peaking in 1991, where for every 100,000 Americans, 215 died. And then it started dropping. And pretty soon we're going to publish that in 2018, the 2018 data is coming out very soon. It's going to be a 31% decline since 1991. That's a significant drop in the death rate since 1991, especially after 90 years of rising. Now, some people might ask, how can this be? What about aging? These are age-adjusted numbers. And so this is really to reflect a population that would have been alive in 2000. If it were alive in 1900, it would be 64. If they were alive in 2017, it would be 152. So, but still 64 to 215 over 90 years. And then all of a sudden, over the last 26, 27 years, we're going to have a 31% drop. Now, cancer is about to become the leading cause of death in the United States. Most people know heart disease is #1 right now. For certain populations, Black women, Hispanic women, cancer is already the leading cause of death, more so than heart disease. Both cardiovascular disease and heart disease rates are dropping in the United States, but heart disease death rates are dropping faster. And so within the next 2 to 5 years, even it's not even 5 to 10 years anymore, you're going to hear that cancer is the #1 killer in the United States. Now, why the decline that we've seen in death rates? Why is early detection? And there is very unwise early detection, by the way. Some of the prostate cancer screening, not all of it, some of the prostate cancer screening that's going on is very unwise. Some of the lung cancer screening is unwise. There is wise prostate cancer screening and wise lung cancer screening, but sometimes it's done badly. Improvements in cancer treatment are also a reason for the declines, as well as prevention or risk reduction, especially the reduction in tobacco usage. By the way, in 1955, 55% of adult men smoked cigarettes. Today, it's 15 to 18%. In 1965, 35% of adult women smoked cigarettes, and now it's 12 to 15%. Although it's about 30% of men and women in West Virginia, I should point out. This is another slide of age-adjusted rates for Blacks, whites, Native Americans, Hispanics in yellow, and Asian Pacific Islanders in this dark blue. And these are the death rates from 1990 to 2017 for these 5 racial or ethnic groups. More on those groups in a second. But you can see that the Black rate has gone down faster than any other rate. The white rate is going down, but the Black rate and the white rate are going to intersect sometime in the 2025 to 2030 realm. Native Americans, which has this incredible noise here, primarily because there's such a small part of the population, 1.5%, not really much of a decline at all. And then there's a disparity between whites and Hispanics and whites and Asians that we frequently don't talk about. Now, these racial ethnic groups are defined by the Office of Management and Budget, generally 2 years before every census. And as that implies, race and the definition of race changes over time. These categories, according to the Office of Management and Budget in the White House, are sociopolitical and not biologic. Indeed, they have been rejected by the anthropologic community as non-scientific. The anthropologists consider them to be political and not scientific. Race changes over time. Barack Obama, according to the OMB in 1970, was white, and according to the OMB in 1980, he was Black. The 1970 definition said you should declare yourself to be the race that your mother considers herself to be. So again, race is not a biological categorization, it's a socio-political construct. Indeed, one of the problems in American medicine is we consider it a biological categorization. It's actually some of the institutionalism of racism is the fact that we consider race a biological categorization and not socio-political. A race, by its very definition from the OMB, is incredibly broad. Now, there are differences amongst populations. There's not as much differences amongst races. Area of geographic origin is actually somewhat specific and scientific, although still can be broad. And then admixture, that means that we're all mutts, we're all mixed up, is really a problem even when we look at area of geographic origin. I'll show you some examples of that. These are some of the 109 areas of geographic origin as recognized in Africa. There's 640 areas of geographic origin in Europe, only because Europe is studied more so than Africa, by the way. When we talk about admixture and mixture, I am the top 6. I am from the top 6 of this category. There are 109 in total. I just listed some of the ones that people would know of, but I'm from the top 6. And I'm also from 6 different European areas of geographic origin. I'm from 12 different areas of geographic origin. So you have to understand lots of diversity. There's a Nobel laureate who said to try to divide the American public into 5 racial ethnic categories is like trying to slice soup. It just doesn't work. Now, when we talk about areas of geographic origin and differences amongst them, G6PD deficiency is a enzymatic deficiency. It's a genetic entity. People who get certain drugs like quinine to treat malaria or Bactrim to treat urinary tract infections will have a hemolytic anemia. Their red cells will start busting, breaking down if they have G6PD deficiency. And there's several different types of genetically caused G6PD deficiency that are, they're actually named by the areas of Africa, India, or the Middle East, or the Mediterranean where they come from. There's a Southern Italian G6PD deficiency, a Greek one, so forth. My favorite is the HLA-B 1502 allele. This is a genetic issue for people who live within 100 miles, 150 kilometers, either side of the Tibernese border. 20% of people who live in that area of geographic origin, if you give them the anti-seizure drug Tegretol, they get sick. Their hands start peeling, their mouth gets raw, and they develop a fever. They can even die from it. But it's due to a genetic illness or mutation that is common among 1 in 5 people who live in that area. That's not common amongst a large number of Asians, which is the racial category, and not even a large number of Thai or Burmese, but people from that one area of geographic origin. Another one is a sickle cell disease. Everybody thinks of sickle cell disease as a Black disease, but there are people who live in southern Greece and southern Italy and the Middle East who have sickle cell disease. And if you go to South Africa, the only people who have sickle cell disease in South Africa are people whose families migrated from up north within the last 200 years. So here we have a disease that many people think of as a Black or African disease. And it's not a Black disease exclusively. It is a disease of a particular area of geographic origin. You can draw a circle with your finger around the area where people get sickle cell disease. And it includes areas where Black and white people live, and there are areas where Black people live where there's no sickle cell, or there was no sickle cell. Now, in the United States, this is again part of our racism. Lots of talk about inclusion in clinical trials, as if Blacks are different from whites, and as if the disparities exist because the drugs don't work in Blacks, but they do work in whites. Clinical trials participation, by the way, should be encouraged because it's actually a way of getting high quality care. I have a lot of studies to show that if a doctor puts 2 to 3% of his or her patients on clinical trials, they take better care of the other 97, 98% than a doctor who does not participate in clinical trials taking care of their patients. Now, there's a lot of discussion about diversity in clinical trials. Is something that we get hung up on instead of going and trying to fix the real problems and the disparities. By the way, these are the representation of Blacks and Hispanics, Native Americans, Alaskan Natives, Asian Pacific Islanders on National Institutes of Health cancer studies. And quite honestly, the only real disparity is in white. I hear that there's a disparity in Blacks, but when we look at the data, I don't see that. Studies of the dynamics of clinical trials, by the way, show that minorities in the underserved are enroll in equal numbers compared to the majority in institutions that have a history of service to those minority communities. There are certain hospitals that do not have high minority numbers. That is true. And those hospitals have a history of not providing service to those minorities. So key is reputation of the institution. Now, there's a lot of talk about biologic differences by race. I've just touched on that. In most cases, clinical trials and single institutional experiences show equal treatment yields equal outcome amongst the races. And the problem in the United States is there is not equal treatment. Blacks are less likely to get adequate care than whites. It's rare that a drug or a therapy doesn't work in a person of a particular race. It's more common that minorities, and I would add poor whites, don't get those treatments. Race is a factor in outcome, but it need not be a factor in outcome. And we frequently studied Black-white outcomes in the past, but we're frequently moving beyond Black and white. And increasingly, there's an interest in socioeconomics and area of residence. More on that in a little bit. Health disparities, low socioeconomic status, that's what SES is, or lack of insurance, is associated with higher stage of cancer diagnosis. And for adults, the Affordable Care Act, or Obamacare, is associated with a reduction in disparities in stage of diagnosis and in outcome. More on that in a little bit, and that becomes even more important when we talk about state-by-state disparities. This is bone and soft tissue sarcoma. This is a type of tumor that's commonly diagnosed in children and young adults. The survival with private insurance versus public insurance, how you read these Kaplan-Meier curves is 200 months. Okay, so this is a long time. This is 200 months here. 0.5 is 50%, 0.75 is 75%, 1 is 100%. At 0, 100% were alive. Well, this is the percentage of private insurance. Oops, I'm sorry, I just advanced that myself. The percentage of private insurance patients who were alive over the 200-month period. The percentage of low-income public insurance, Medicaid patients alive over the 200 months. I just put this in because it's not that Medicaid is bad, it's that the people who are poor and have Medicaid very frequently present later without the Medicaid. They get the Medicaid at diagnosis. They don't have Medicaid until they get diagnosed. So they will ignore symptoms, ignore the fact that they have something growing in the body that sometimes they can even feel. Unfortunately, socioeconomics is really important. Poor people, including poor whites, more often present with distant disease. They're less likely to receive adequate care, especially expensive care like radiation therapy. And when they get radiation therapy, the quality of the radiation is different. The doctors may not be as good at aiming the beam. The quality of the machine is a huge issue. Indeed, as we look at radiation therapy given around the country, Poor people tend to be treated on machines that are 20 years old. Indeed, sometimes the machines that would never be allowed at what I'll call highfalutin hospitals like Johns Hopkins. Cancer disparities are due to differences in access to quality care, with the emphasis on quality. There's been a lot of emphasis on access to care, but not access to quality care. And then there's a difference in utilization of that available care. Poor people, even when they have insurance, are less likely to utilize that insurance. Now let's go back. You wanted to hear some race stuff. In 2019, the American Cancer Society, which I used to work for, published that these were the numbers diagnosed with colon and rectal cancer. And for death, they give one number for colorectal cancer. There's been a 50% decline in colorectal cancer death rates in the United States since 1981. That means that since 1981, if you have give me an average 60-year-old person today, their risk of death from colorectal cancer is about half what it was for your average 60-year-old in 1981. So there's been a 50% decrease in risk of death. That is amazing. It's one of the greatest declines in death rate for any disease in the United States. Now, when we look at females, this is from 1975 or so all the way to 2015. You can see in the 1970s, there was no black-white death rate disparity. This is deaths per 100,000. In 1976, for every 100,000 Black women, there were 25 who died from colorectal cancer. And for every 100,000 white women, there were 25 who died. There was no disparity. And then as we move into the 1980s and beyond, we see the disparity between Blacks in red, whites in blue. As these lines get further and further apart, the death disparity is getting further and further apart. And then finally in 2000 and beyond, the death rates start getting closer and closer for Blacks and whites. Now, Ronald Reagan, by executive order, announced that by 1990, we were going to start collecting data for Native Americans, Asian Pacific Islanders, and Hispanics and publish them. So we have data from 1990 on for those three racial ethnic groups. But we go back to just after Richard Nixon signed the National Cancer Act to have this data for women with colorectal cancer. Now, this is men with colorectal cancer. Again, very similar Black versus white. Blacks actually had a little lower death rate, about 30 to 33 per 100,000, when whites were at about 34 per 100,000. Then they were very close around 1981. And since 1981, you can see the disparity again. Now, this is Black versus white. And you can see the whites have a disparity with Native Americans, Asian Pacific Islanders, and Hispanics, okay? So that's racial disparities. Now, I told you there's a 50% decline in the United States overall since 1981. Let's look at it state by state. The purple states have had a 12 to 31% decline since 1981. The dark blue states have had a 55 to 63% decline. More and more, as we look at disparities, and we used to think of disparities as Black-white. Now for colorectal cancer, I'm thinking about Mississippi versus Massachusetts, 12% decline versus 63% decline. It's very interesting that we were all very equal in the 1970s by state. And then all of a sudden, some states got a dramatic decline, other states not so dramatic. Now, this is one of those Kaplan-Meier 5-year survival plots again. This is 60 months on the x-axis. And here 0.5 is 50%, 0.8 is 80%, 0.9 is 90%. This is stage 1 colorectal cancer in red, stage 2 colorectal cancer in blue. I'm sorry, this is a little complex, but the solid lines are people who had private insurance. And the dotted lines are people who were either uninsured or they got Medicaid after they went to an emergency room with blood in their stools after passing out or abdominal pain, and they were diagnosed with colorectal cancer. The social worker goes and finds the Medicaid after the diagnosis. And this is to show you that at 5 years, people are better off having stage 2 more advanced colorectal cancer with insurance versus stage 1 less advanced colorectal cancer without insurance. In the United States of America, you are more likely to be alive at 5 years with the more advanced colorectal cancer with insurance. As a matter of fact, even with stage 4 widely metastatic disease, people with insurance are better off than people without insurance if your goal is to live. Studies suggest that disparities in treatment are due to cultural differences in acceptance. There are people who say no. Disparities in comorbid disease making aggressive therapy inappropriate. People who have diabetes, hypertension, morbid obesity, have not expanded the Affordable Care Act. Even in states like Maryland that has no, there's very few uninsured people in Maryland right now. Transportation is still a huge issue in getting people adequate care, getting them to the doctor for various therapies. And then, of course, racism, and there's discrimination against the poor, socioeconomic status discrimination. We see chemotherapy that is underdosed. I'm a medical oncologist, so I have to talk about chemotherapy. We see it underdosed because of obesity and the physician concerned about side effects if they give the dose that's actually called for. We see failure of dose intensity because people fail to keep appointments. One of the principles of giving chemotherapy is you want to get as much drug into the patient in as short a period of time. If the patient's not coming back every 3 weeks, you lose that dose intensity. Now, I already told you about radiation therapy machines that are older and of lower energy. Literally, a large number of poor people get treated on 20-year-old machines, and a large number of middle class and wealthy people get treated on machines that are less than 5 years old. And we find that healthcare facilities can be overburdened, and that can delay getting treated or delay quality of service. One thing that we didn't even think about until Kim Rhodes at Stanford did this study, she found that hospitals that are overcrowded, that treat a lot of Medicaid patients, the pathologists are overburdened and overworked, and they don't study the pathology. They don't dissect out and work on the pathology as well, and they end up not staging patients for cancer as well. These are the hospitals that have a lot of Medicaid patients, have a lot of minorities and poor people there. Indeed, she found that Blacks who are understaged are frequently called stage 2, and whites who are very intensively staged because they're treated in a number of hospitals that the pathologist has only 1 or 2 patients to deal with per day. The Blacks in hospitals where the pathologist has 5 or 6. And some of the things that we see that we think are due to race are actually because the Blacks are in hospitals where they're terribly understaged. I showed you colon cancer. Let's look at breast cancer. There has been a 40% decline in breast cancer risk of death since 1990. That's to say your average 60-year-old woman today, her risk of dying from breast cancer is about 60% what the risk was of your average 60-year-old in 1990. These are the numbers diagnosed and dying in 2019. Screening is due about half, a little less than half of that decline. Improvements of treatment are a little more than half of that decline. This is that same death rate over time from 1975 onward blacks in red, whites in blue. Again, you see, there was no black-white disparity in the 1970s. Then we learned how to screen and treat this disease, and that's when we start getting our disparity. The same as in colorectal cancer. We learn how to screen and treat for the disease. That's when we start getting the disparity. And here in breast cancer, the disparity is greater today than it's ever been. You can see there was no disparity in 1981, and then all of a sudden we have a disparity that's greater today. And then you can see the other three racial ethnic groups. Now, we talked about racial disparities. We were all about the same in the 1980s. And then there's these purple states that have a 20 to 29% decline now in breast cancer death rate. And these dark blue states that have a 44 to 51% decline. And here we have to ask, what's the difference between Mississippi and Massachusetts again, the 20 versus the 51? Sorry if Mississippi's not looking good tonight. Okay, here again, you have the racial disparity. Okay, now, you see the black-white disparity here? There's 7 states where there's no black-white disparity. There are 6 states that have no black-white disparity because the death rates are some of the lowest in the country. And then there's West Virginia, where there's no black-white disparity and has some of the highest death rates in the country. There are also 12 states in the United States where white breast cancer mortality is higher than the breast cancer mortality of Black women in Massachusetts. Again, this is a disparity in access to care, and it's not just access to care issues for Black women. Now, there's a lot of people who always talk about screen, screen, screen. I've had huge arguments with Congresswoman Debbie Wasserman Schultz from down there in Florida, because she's always in the screen, screen, screen. And the facts are that we know that of the 45,000 women who die every year from breast cancer, about 10% of those deaths could have been prevented if either they had gotten screened or they did get screened and the doctors didn't call the mammogram appropriately. It's about 10%. It's about 21 to 27%, 2 to 3 times as many who die because of failure to get adequate treatment after diagnosis. And I never hear politicians say, get adequate treatment, get adequate treatment, get good high quality treatment. They always say, get a mammogram. And by the way, the message should not be get a mammogram. The message should be get into a program of routine high quality mammography. I don't want a woman to get a mammogram. I want her to get routine mammography every 1 to 2 years. 2 years is actually good enough for most women, but if they want to do it every 1 year, I'm more concerned about it being routine and the woman having previous mammograms for comparison. So there's a tremendous overemphasis on screening and an underemphasis on adequate treatment. A substantial number of women get less than adequate treatment, be it surgery, chemotherapy, radiation, or hormones. Paper that Mary Jo Lund, one of my fellows, published about 13 years ago, 7.5% of Black women, and by the way, 2% of white women, who got one of those messages about get a mammogram, got diagnosed with breast cancer and did not get treated within 1 year after diagnosis with a low stage curable breast cancer. They had enough access to care that they got a breast biopsy after a mammogram. So getting people into care is a huge issue. I should also point out that there are certain populations where Black women do much better than Black women in the United States. Black women who are retirees of the military or married to retirees of the military have a much lower risk of death than Black women in the United States as a whole from breast cancer. And in Chicago, just over the last 20 years, with some very interesting, innovative work, they have actually decreased the death rate for Black women in the United States. A lot of talk about biology being different for Blacks versus whites. And it is true that 24% of Black women have what's called triple negative disease. 12% of white women have triple negative disease. Oprah makes it sound like all Black women have triple negative disease. 76% do not. Okay, and it's important to note that the disparities in treatment that kill Black women are disparities in that 76% who do not have triple negative disease. Factors that cause triple negative disease, by the way, and are probably causing Black women to have a higher percentage of triple negative disease are obesity, some dietary differences, especially dietary differences in childhood, causing bad breast cancer when the woman's 40 or 50 years old, some reproductive differences, and not breastfeeding. Not breastfeeding, social issue is heavily influences risk of triple negative breast cancer. This is a shame. You know, when I was a medical student at the University of Chicago, and I hear it's still done, when a young woman left the hospital with her baby, she got sent home with a case of formula. So the society is literally encouraging these young women not to breastfeed, not to mention they have to go back to work and so forth. But that actually comes back to bite these women 20, 30 years later and cause these more virulent tumors. And by the way, there are European studies that tell us that these sorts of things cause more virulent tumors. So the Scots have done this beautifully. They started noticing that poor women had more virulent tumors, more triple negative disease, and they didn't have these blinders of racism. They didn't say, what is it about being Black that causes triple negative disease? There are very few Blacks in Scotland. They said, what is it about poverty that causes triple negative disease? And that's how we started learning about breastfeeding, obesity, and so forth. By the way, about 15% of Black women were obese in 1970. Here's obesity in Black women in 1988 to 1994. And now today, 60% are obese. This is obesity and not overweight. And we've had a rise in literally the entire American population, but it's especially bad for Black women. So a substantial number of women of all races and incomes get less than optimal care, and that can be screening, diagnostics, as well as the various modes of treatment. Racial minorities and the poor are more likely to get less than optimal breast cancer care, but it happens to whites too. The last couple of slides here. A couple of years ago, I and a group at the American Cancer Society tried to figure out how many people suffer from cancer health disparities. Well, we figured out that college education is an amazing thing. College prevents cancer death, it prevents diabetes, it prevents cardiovascular disease. If you give a college education to a Black man, his risk of dying from cancer becomes lower than the average risk of white men in the United States. If you give a college education to a white man, his risk of dying drops even further. And so we just asked the question, if every American had the risk of death of college educated Americans, how many people would die? And the answer is about 468,000 would die. 132,000 of the 600,000 would not die if everybody had risk of death of college educated Americans. 132,000. That is more than any screening test. There's never been a breakthrough drug in cancer. Indeed, until the coronavirus vaccine, there hadn't been a breakthrough drug in medicine that had prevented 132,000 deaths in 1 year. The COVID vaccine is going to prevent close to 200,000 deaths this year. It's the most effective drug we've ever developed. But anyway, 132,000 deaths would go away if we gave every American what college educated people get. That's the disparity. We went a little bit further. Of that 132,000, who are they? Well, it turns out the largest number of 80,000 of the 132,000 are white, tend to be poor, tend to live in those purple states that I showed you. And so the issue of disparities in health is not just a racial issue, it's really a socioeconomic issue. I showed you this before. How do we get adequate care from prevention and risk reduction all the way through screening, diagnosis, treatment, and palliative care to all human beings? So that's the most important question we can ask. We need to be scientific because unnecessary care causes disparities. There are some groups of people, sometimes it'll be Appalachian whites, sometimes it'll be Southern whites, sometimes it'll be inner city blacks who need a little bit more to get where we all want to be. They need a little bit more than other groups. We don't need equality, we need equity. And I'm going to end with this. This is what the old Johns Hopkins Hospital looks like. That's where Sir William Osler was one of the inventors of internal medicine, and Halsted invented the breast cancer surgery that we no longer use today. And so I'll stop sharing at that point and see if we have some questions. Did I lose you guys?
No, we're here.
Okay.
We're here. I'm waiting for Alicia to start my video. It's not letting me start my video. Here we go. Here I am. Okay, no, you did not lose us. I have a question. It was Alicia's question as well. You were speaking very clearly and eye-opening about the differences, the problems that come from defining race as a biological function. And Alicia and I both watch, here's the question, we both watch Grey's Anatomy, and this week, did you see it?
No, I
In
didn't.
your spare time? You know, you're not busy. But there was here was what happened. She wrote it out. For kidney transplant eligibility, the EGFR is a factor and is measured differently for Black people based on the myth of biology. And therefore, Black people do not get on the transplant list as they should. Is this being addressed in the medical field? Moreover,
that's a huge issue. There's a lot of discussion about that in the medical journals nowadays. And the answer to your question is that you are absolutely correct that for about 50, 60 years, there's been a Black correction in renal function, and we're starting to realize that that's garbage. And we're getting rid of it.
I'm assuming that's not the only place where this is a problem.
Yeah.
How widespread do you think this problem is beyond the renal function?
Well, we've actually had, in the past, we've had corrections for white blood cell count, a few other things. It's a problem. You know, a lot of the original numbers were based on the average size white male. And so there's a problem. There's a problem that we do need to have differences in certain instances, like male female, where the biology is very different. And then there are other instances where we've created these differences that were just garbage. There's lung pulmonary function differences as well. You know, a white man's lung capacity is apparently not supposed to be as big as a Black man's lung capacity if you read some of the pulmonary books from 20 plus years ago.
Terrifying. Okay.
Oh, it gets better. By the way, in the 1930s, they used to have skin color charts for Black people, and the lighter the Black person's skin, the more intelligent they were thought to be.
Okay. What can be done in vocational education that would allow people who did not go to college to receive the benefits of white people who do?
Yeah, I'm looking at that a lot. There's certain things that we need to teach people. There are some people who have been poor, who got rich, sometimes forget what it was like to be poor. And we've been studying diet is different, how people eat, what people eat, especially when you get into inner cities now, it has changed dramatically. I do surveys of what people eat, and sometimes I've literally done surveys, and a substantial, 5-6% of people in the inner city of Baltimore. The only vegetables that I've had in the last week were lettuce on Big Macs.
It's pervasive.
Pervasive is the right. Yeah, one of the issues in some of the big cities, in Baltimore, for example, which I'm studying intensively, there are no grocery stores in the poor inner city. If people could afford to buy vegetables, there's no way to buy them. All food is purchased from the dollar store, and the business plan of the dollar store is canned goods, foods in jars, things that don't spoil, things that have a long shelf life. And there is a plethora of fast food.
Okay. Everyone, please post your questions in the chat. So this says, not a question, but a comment. Wonderful talk.
Oh, thank you.
In all caps. I agree. Yeah, so more questions, everybody. But no, I think that your presentation was so enlightening, and it's things that you kind of know, sort of,
Yeah.
but to have it put out like that,
Oh.
that really all of this is 99.9% of this is socioeconomics.
This is, you have to remember that this is a friendly audience in many respects. I'm preaching to the choir. There are times I give a talk like this and I literally have to do the rope-a-dope off the stage. If you're too young to remember Muhammad Ali.
I promise I am not. No, I'm not too young. Yeah. Sorry, I had something I was going to say, and then I read a question in the chat. So I'll read you the question in the chat. Florida, especially, I remember what I was going to say, but I'll read this anyway. Florida especially needs Medicare for all. Why the resistance? What can we do? And then someone said, is the benefit from college education perhaps a reflection of socioeconomic status rather than the education? Yeah.
Well, I'm going to be honest here. I'm not trying to be political. I'm just trying to be honest and just fact.
Deeply political. It's a political issue.
We have a lot of people in this country who are very individualistic and don't care about other people. The reason why people should be taking the coronavirus vaccine is more to protect other people than it is to protect them, especially if they're young folks who think that they're not going to die from coronavirus. Keep their people, some of them are my patients, who the vaccine, even though they get it, their immune system is not going to respond and you're still vulnerable. And if we can vaccinate all the people who they're typically exposed to, we still protect those people from coronavirus. But the individualism in America doesn't allow for that. Now, the other thing which some people might find distasteful, which is the following, which is absolutely true. Dr. Deborah Birx says that the mishandling of the coronavirus vaccine last year by the White House, the confusing messages about masking, the fact that our leaders would not lead by example in mass, the fact that our leaders were holding campaign rallies which were and literally became mass spreader events where some supporters of President Trump died of coronavirus after being at those mass spreader events. She says that mishandling cost at least 100,000 lives, and there's a question as to whether it's up to 200,000 of the 500,000 who died from coronavirus last year. Now we have doctors who worked for politicians saying that those politicians' mishandling cost at least 100,000 lives. We have governors, one of which is the governor of Florida, who are doing things that kill people. And nobody gives a damn. Unfortunately, they are doing things that kill people, and many people, I should say, don't care. Now you're asking me, why can't we expand Medicaid to help people who are just silently dying? The coronavirus people are out there on the front page of the newspaper dying, and nobody wants to fix that problem. So I'm sorry.
No, I think that's an excellent answer. And that was the frustration I experienced the other day that I was going to comment on. Someone on Facebook, was like, why should our tax dollars pay for education? Why should they pay for free college? If you want to go to college, take out. And that's such a very simplistic outlook that misses all of this cascade of other issues that your presentation has spoken to here, that people just don't have even scratching the surface of.
Yeah. And part of the unfortunate truth is if we paid attention to these things like prevention of disease and trying to avoid suffering, trying to avoid death and suffering from coronavirus, diabetes, hypertension, cancer, all of these diseases, the economy would actually do better. And we as a country would be wealthier. And there's a bunch of folks who don't realize that they're literally working in their own worst interest.
Right. For the reasons that you just said about our self-serving. All right, our time is up. We have 2 more questions. Can you answer 2 more questions?
Sure.
Okay. All right. Why are Black women more at risk of dying after giving birth?
I don't know the whole reasons. It may have to do with doctors not paying as much attention. It may have to do with the hospitals that, there's a lot of segregation in our hospitals right now. Some of my colorectal cancer statistics are definitely skewed by the fact that in California, 80% of the Blacks with colorectal cancer are treated in 15% of the hospitals that treat colorectal cancer. We may have something like that with Blacks in birth as well. Some of it is socioeconomic, but there are some middle-class educated Black women who are, it's been shown the middle-class Black women who are educated are more likely to die than their peers. Less likely to die than less educated Black women, but more likely to die than their white peers. So I don't know the answer to your question. I just gave a non-Washington answer, and I'm in Washington. I admitted I don't know.
So refreshing. Okay, so last question. What is your suggestion for policy change?
My suggestion for policy change, if I were czar of the world, if I were trying to create an intervention that was going to fix a lot of these health things, I would start trying to teach people how to be healthy in 2nd and 3rd grade, and try to teach them how to carry the message home to their parents. I'd love to see 3rd grade kids nag mom that they want vegetables, for example. I would try to get everyone a health coach. Many of us, when we go to the gym, we have a trainer. I would love to see everyone have a trainer to teach them how to eat, how to exercise, even how to sleep. And we need to do a lot of health promotion education. And so those are some of my solutions. And I just wish I could impact upon everyone a little bit more empathy and a little less individualism. I was raised, I went to a Jesuit Catholic school where they always taught us that we were supposed to be men for others. And I still believe that I would just change it, that we should be men and women for others now.
Okay, well, I won't keep you.
Oh, I'm fine. If you have other questions.
Well, I think people stopped posting their questions probably because I told them we were out of time. So this has been extraordinary. Alicia says, terrific presentation, lots of praise. So honestly, if you all want to unmute yourselves and share your praise, you can do that now. I'm seeing hands up and clapping.
Thank you.
Yay, thank you.
Thank you very much.
That's great.
It's really important because even like you said, you're preaching to the choir, but the choir sometimes can oversimplify things and say, oh, it's because of racism or implicit bias. And it is, but it's a deeper level than that. It's a systemic issue, not a one-on-one issue exclusively. And I think that what you presented here really illuminates that.
Thank you. Thank you.
Thank you
Maybe
very
you
much.
could do an
Dr.
empathy
Brawley.
vaccine.
Empathy vaccine.
Thank you.
And
Empathy
yes, tell
vaccine.
Dr. Brawley we want an empathy vaccine.
He can hear you.
What
City are you in, Dr. Brawley?
Say again?
What city are you in? What hospital?
I work for Johns Hopkins.
We
In
have a John
Baltimore?
Hopkins here in St. Petersburg.
Yeah, it's all Children's
Yes.
Hospital in St. Petersburg. No, I work at the original Johns Hopkins in Baltimore.
Yes, it's a great hospital.
Yeah.
He's fancy, I'm telling you. So we are very fortunate for him to share his knowledge and wisdom and expertise.
Everyone should hear what you have to say.
Oh, thank you very much.
So this is all in mostly in your book?
No, the
No.
old book, not the old book. It's in the new book.
When's the new
will be
book?
Coming out next year.
Okay. All right. We'll keep an eye out for the new book. Thank you so much.
Thank you.
Thank you very much.
Sure. You take care.
All right. Do you mind if we share the recording of this?
That's fine. That's fine.
Wonderful.
We'll share it with you as well, Dr. Brawley.
Thank you.
All
How
right.
do we get the link?
Thanks a lot.
Thank you.
You all have a good night.
How do we get
You
the
too.
link?
And
Bye.
thank you so much, Cynthia. I appreciate everything.